So I'd like to welcome you to this program tonight. As you know, I'm going to be talking about Alzheimer's, dementia, and the brain. Now, my goals for today are to have every single one of you, whatever question you have about dementia and Alzheimer's, have them answer. So for those of you that have little information or knowledge about the condition, I hope you get out of here today with a little bit better understanding about the brain function and dysfunction as it relates to dementia. Now, for those of you that have more advanced knowledge of the brain function and Alzheimer's disease, I'm going to cover some more specific areas. So there's going to be some times that the conference may be a little bit off level for you, but don't worry, there's going to be no test. There's nothing that you're going to be missing. And at the end, the most important messages of the conference you're going to get. So pay attention, hold on, and hopefully we'll have a good time over the next hour. I'm going to try to limit the conference to about 50 minutes, and we still have about 20, 25 minutes at the end for questions, okay? So let's go. So what is it that makes the brain so important? Why do we have so many people here to hear about the brain? Well, the brain is the most important organ of the body. You know, everything else in the body is to support the brain. The brain doesn't have energy areas. Everything depends on the blood flow coming into it. The brain is super protected by the skull on the top and then a capillary system in the bottom. And everything we do and everything we are is because of the brain. The brain is considered to be the seat of the soul. So our connection with ourselves, others, and God, it's in the brain. In the old days, they thought it was the heart, but that's all literature. So clearly, it's the most important part of our body. What exactly does it do? How does it work? Has been some of the biggest intrigues of humans. And we're going to cover a little bit of that. Obviously, there's far more that we're going to cover today, but hopefully we'll give you some interesting and important insights about brain function and dysfunction. So, when people think of the brain, they think of it as another organ. But the brain actually is a group of organs lumped together. The organ of thinking, concentration, speech, comprehension, movement, coordination. All of those are very different functions, all obviously performed by the brain. It only weighs about 3 pounds. So even though it's only about 2% of the adult body weight, it receives about 20% of the blood flow that comes from the heart. So as the heart pumps, 20% of that is to support the brain function. It's a very active organ. It consumes a lot of oxygen. It's mainly made out of water, like most living tissues and organisms. Now, nobody has sat down to count the number of brain cells on the brain, but people estimate that there's about, it's about 2 to 10 billion neurons. Okay, the neurons are the functioning, the basic structure of brain function are the neurons. But besides them, we have a number of other cells, and actually only about 1 out of 10 cells that we have on the brain are neurons. So there's a lot of other cells. We call them the glial cell that perform very important function on how the brain works. The cells don't touch each other, so they communicate with each other through neurotransmitters. And many of them you're familiar with: dopamine, acetylcholine, serotonin, just to name a few. There's at least 70 different naturally occurring neurotransmitters, and at one single time in the brain, there's about 100 trillion active synapses at a time. I think this is the only place where I've ever seen a number that is bigger than the US debt. Now, about 1/3 of our genes are active in the brain. So when I say that the rest of the body is meant to support the brain, I really mean it. So before the last part of the 19th century, when scientists would look at the brain, there was not a whole lot to see. They would look at it and it would look like Play-Doh, like pudding, like ice cream. There was nothing that they could differentiate until this gentleman, Camillo Gaudier, an Italian scientist who was already famous for his work on malaria and other areas of science, he was working on his kitchen, which was also his laboratory, and accidentally he had a piece of brain fall into a petri dish with a product called silver nitrate. So what did he do as a scientist? He took it out, he put it under the microscope, he looked at it under the microscope, and for the first time ever, we were able to look into what was going on in the brain and realize that was our entrance to the microscopic examination of the brain. It was the first time that we humans have an idea of what was the brain made of. So soon after that, using the Gaudier technique of staining brain cells to look at it, the famous Spanish neuropathologist Ramon Santiago Cajal, who was an artist whose father asked him to study medicine, he, using the silver nitrate, looked at the brain, and he made the first drawings ever of how does the brain look microscopically. And this was his initial painting, the first illustration we ever had about the brain. So here, if you can see where the pointer is, these are neurons. And as you can see, there's a lot of space in between that on this painting, we don't see any other cells, but that area is full of other cells called the glial cells. Now, this is a drawing of a neuron, okay? So the neuron has, as I said before, there's many cells in the brain. There's trillions of synapses. The synapses are the connections between the brain cells, and every single neuron in the brain connects with about 2 to 10,000 other cells. So if you understand the complexity of it, I think anybody that say that they really understand how the brain functions, please don't trust them, okay? Including myself. So, and this is a very simplified drawing of the neuron, showing the body of the neuron, and all of these are connections with other cells. The neuron have what's called an axon, which is a long part of the nerve that help connecting with other cells. And we'll cover a little bit of this. I'll try not to keep you bored, okay? So, the brain is a great organ. It functions very well. It is the best computer that we have. Nothing works like the brain. The brain, when we're born, we have most of the nerve cells that we will have through the rest of our life. And at the beginning, at birth, right here at birth, we have all those nerve cells. And then between birth and 20 years of age, this is age, okay? And this line here is the integrity of the central nervous system, meaning how good is the brain working, okay? So in our younger years, the brain starts to get connections between each others, and by age 20 to 25 is when the brain is considered physically mature, okay? That's the age where the brain should be functioning well, very effectively. Different than emotional maturity, but physical maturity. So from then on, from 25, 30 years of age, the brain, and let's focus on the top line, the brain starts to age, and as the brain ages, we start to see a decay on the brain function, up to the point that if we live long enough, and the maximum lifespan, meaning how long a human can live, is about 120, 122 years old. So if we live long enough, most people believe that we will all develop dementia. So in a normal person, in average, by normal aging, by age 85, half of us will be getting dementia or getting close to having dementia. Now, there's some other genetic factors. There's some other metabolic problems. If you have brain injuries, if you have stroke, if you have some genetic predispositions, that will shift the curve to the left, meaning you will get the dementia at a younger age. For example, we know there's some genetic factors that will make you have dementia in about your 50s. People with Down syndrome They produce a lot of amyloid, which is a protein of the brain, present in the brain. And these people by age 45 or after, they will all have Alzheimer's type dementia when you look at people with Down syndrome brain. So dementia, and we'll get into the difference between dementia and Alzheimer's, which is a common question. Dementia, we know that it doubles every 5 years since age 65. So if we look at the, incidence of dementia by age 65 is about 2.5%, meaning 2.5% of us, by the time we turn 65, will have dementia. By age 70, it's about 5%. It's about 10% by age 75, 15-18% by age 80, and about 40-45, in some studies up to 50% by age 85 will have dementia. So the question that has been raised in medicine through the years is a point that I already mentioned, which is, if we all live long enough, would we all have dementia? And by the way, it's important for me to define dementia. Dementia is when we lose our mental skills up to the point that we are unable to function independently. Now, I think everybody here knows that we become forgetful as time goes by. You know, finding things become a little bit harder. But in general, if you're able to maintain your level of function, if you're able to drive and typically don't get lost, if you're able to still do most of the things that you were doing before, you know, it's not considered dementia. But by the time when your mental skill decrease enough up to the point that you're unable to function independently, that's what we call dementia. Okay? So, if we live long enough, we will all have dementia. And this was the topic of this article in one of the main neurology journals. As most of you know, I'm a neurologist. And this was published a few years ago. And the important thing about this article is that we have known for a long time that by age 85, dementia doubles every 5 years, as I showed you already. But they felt that nowadays that we have a lot of people living through their 90s and above 100, we wanted to know what happened to those patients. Does the risk of dementia continue to increase? And what the answer they found was yes. They look at patients over 90 years of age, and they realized that the risk of dementia after 90, it continued to double every 5 years, mainly for females. Now, females have slightly increased risk of dementia. Now, don't take it wrong, we have a lot of other problems. And the risk of dementia in males, it also continued to increase, maybe a little bit less for males. But yes, as we get older, like everything else in the body, it gets worse, and dementia will settle in. Now, a couple of years ago, people have been relooking at this issue. Now, people have been saying, well, what about if we eat healthier? What about if we don't have diabetes or high blood pressure? What about if I continue to exercise? What about if I avoid my stress, sleep better, live a healthier life? Would that give me a better chance of living longer and healthier? And the answer is obviously yes. You know, the healthier you are, the healthier you keep your body, the better you control your stress, the better you treat your depression. Those things improve the risk of dementia, but they don't eliminate the risk of dementia. You know, a common mistake in non-medical people when they talk about prevention in medicine, we never talk about eliminating the risk. Prevention in medicine meaning decreasing the risk. If you take aspirin, does that mean that you're never going to have a heart attack? No. You know, if you eat healthier, you're not going to get colon cancer? Not necessarily. So risk factors increase chance or decrease chance, but prevention medication, prevention treatment never eliminate chances, okay? That's a good message to keep in mind. But anyway, so they look at the study. What about healthy people? What about people when we're treating, now that we're treating blood pressure aggressively, treating diabetes better? Hopefully in the next few years start controlling obesity a little bit better. Could dementia decline And this is one of the studies, and basically they felt that, yes, in a healthy individual, you can improve your chance, but overall, the difference in dementia incidence were non-significant, okay? We'll get back to some of these points, okay? Don't want to get you discouraged yet. One of the things I found interesting in my practice is, we're all getting old, You can see it on the hair, you can see it on the wrinkles, you can see it on the glasses, you can feel it on your joints and muscles. But most people feel like, okay, it's okay if my lungs are not that good, if my kidneys are failing a little bit, if my heart's a little weak, but no, not my brain, please. But the fact is, like the brain, just like any other tissue, it ages like any other tissue, and it decays with time, okay? I'm making this point because I hate the commercials and the advertising trying to make fear out of dementia, and the fact is that if we live long enough, you have to assume that at some point the memory will decay. So there's something called life expectancy that we all know, which is somebody born now, how long are they expected to live? Somebody that is now 50 or 60 years old, in average, how much are they expected to live? But there's something called lifespan. A lifespan is a genetic limit to life for an individual. So for humans, our lifespan is about 85 years of age. Exactly the same number that we were talking earlier, that half of us will have dementia. And actually, if you look at many other diseases, by age 85, most of us will have some kind of cancer, heart disease, and a number of other problems. And the table that I showed you earlier of risk of dementia in doubling every 5 years, that also holds true for many other medical problems. So the point is the following. The point is that the body is not meant to live forever, okay? Now, there's a couple of important things on this slide. And I know this is a busy slide, and I have trouble reading it from here, so I can imagine you probably can't either from there. But, in one of those first slides that I show you how the brain starts to mature until we're 20, 25 years old, and then start a slow decline. So that is the physiology, the function of the brain. It matures until we're 20 to 25, and then a slow decline. Trust me, we are all going through that slow decline now, and then eventually it comes quicker. However, besides the physiology, which is the structure function of the brain, we have the aptitudes. So as time goes by, that's more of a maturity. So there's things that improve with age. Like, for example, cognitive powers peak at about age 22. It begins to decline at age 27. And as time goes by, the processing slows down. But this is another important curve. This green curve is about the emotions, okay? And it's important because few things get better with age, but emotions often do, okay? So at least something we need to take advantage of. So when you look at happiness, it tends to improve when 20 to 40, from 30 to 60. People become more calm as time goes by. It's easier as we mature to be able to understand somebody else's opinion or point and be able to compromise, except if you work on the Congress. So impulse control, decision-making process, judgment, or what is thought as wisdom, that tends to improve as time goes by. This is a table of life expectancy. Remember, we were talking before about lifespan. Lifespan for elephants is, 85. For turtles, it's a little bit more. For us, it's about 85. But life expectancy in the 1900s, so just over 100 years ago, it was about 48 to 50. So that's what most of us were expected to live if we were lucky. And that's been increasing slowly thanks to sanitation, vaccines, medication, treatment of blood pressure, et cetera, et cetera. And we are, in some countries, approaching that 85 years of age. Here, we are about 78 for females, a little bit less for males, but that's the life expectancy, and it's been increasing, but it's been plateauing lately. And most of us believe that we're going to get close to a life expectancy of 85 in many countries. And unless there's some genetic changes that can be done in our body, that's not going to increase any further. So another important message that I want to bring to you today is this. The body is not meant to endure the years that one may live. So as we get older, you know, more things will happen, and we have to just start adjusting to it. Same thing happening on the brain. As we get older, we go from normal aging to something called the gray area, or we define it in medicine as the age-related memory loss, okay? And from age-related memory loss, we go to what's called mild cognitive impairment, which is when we start having some forgetfulness, maybe a little bit more than expected for age, but we can still function well, meaning we don't have dementia. And from there, we'll have dementia. So what happens on the brain? What does the brain decay? And what do we know about the factors that cause the decay in the brain is what we're getting at now. So just a few minutes of some scientific detail, but hopefully it'll give you a good insight of the brain. And again, this is also very simplified. But again, here we have a famous neuron. I think you're being able to recognize it. A neuron, the nerve cells. So this is a normal neuron. This is the nuclei. These are the dendrites, and these are the axons. This is the axon. So in the brain, in the brain cells, many things can go wrong, causing cell damage. But there's two particular parts of the brain cells, of the neurons, that I call them the weakest link. They're the parts of the neurons that are more prone to damage and are the parts that are more commonly associated to Alzheimer's dementia and brain decay. And those are, one of them is a protein called the amyloid precursor protein. The word amyloid, I'm sure many of you are familiar with. We're going to hear more about that today. And there's another, and the amyloid precursor protein, I'm sorry I cannot pronounce that well. It's a protein that is on the membrane of the cells and that is overproduced, or sometimes it becomes insoluble and it precipitates between the cells, causing what's called the amyloid plaque, which is one of the hallmarks of Alzheimer's dementia. And then we have the tau. It's a tubular associated protein. So in this axon, you know, normally the brain cells produce neurotransmitters, and those are produced here on the body of the cells, and they're transported back to the terminal parts of the cells by it's like a hinge mechanism that it's like a pulley mechanism that take those neurotransmitter vesicles, bring them to the back, and then they're secreted to other parts of the cells. And that system, that railroad or road system within the cells, it's dependent on this protein. In Alzheimer's disease and in other types of dementia, there's some genetic predisposition and some factors that lead to decay on the tau. So those pathways, those mechanisms crumble, the system gets damaged, and then the cells die. So damage to the tau protein, again, which is a protein within the cell, and to the amyloid precursor protein are the two of the more common things that scientists have been looking for many years as the cause of Alzheimer's, and understanding those, we've been able to are developing medicines that hopefully could help treating Alzheimer's now and in the future. I love this picture. It's a little complex, but let me take you briefly through it. So here we have the famous neuron, and on the membrane we have the amyloid protein, okay? And in that space between the nerve cells, we have the glial cell, which are other cells. So this protein is produced. Young people, healthy people, small amount of amyloids. The body can handle them and eliminate them well, but as we get older, there's some genetic predisposition, there's some damage to the way the cell clear those, and then they precipitate it, forming the amyloid plaques. Okay? So for years, back in the 60s and 70s, when people talk about dementia, they would talk about cerebral atherosclerosis. And then they realized, like, oh, there's no atherosclerosis. This is all related to amyloid and plaques problems. Well, it turned out that atherosclerosis, or hardening of the arteries, is a problem that predisposes to dementia. And right now, we're on the process of understanding that dementia and most of the cases that we now recognize of Alzheimer's, they do have a combination of damage to the cells, like with affection of those proteins that I was showing, associated with atherosclerosis. So I don't know if you're familiar with, but for many years there's been a study going on in this country called the NON studies. So the NONs, this physician from Kentucky recruited these NONs. And the NONs are a great group to study because they typically live a healthy life, eat in moderation, don't drink too much, they tend not to smoke. They stay, physically active, they like academics, they like to study, they tend to live a good life to our standards. And one of the things they realized that they have studied these women, some of them on their 80s and 90s and 100 years old, many of them that were mentally perfectly fine. They have studied them within months of their death. By the time they die, they look at the brain under the microscope. Many of them have the amyloid plaques, the tangles, meaning the hallmarks of Alzheimer's disease, while they did not have dementia. Well, the ones that have dementia, they tend to have the classic Alzheimer's pathology, meaning the plaques and tangles, in top of white matter disease, in top of vascular dementia. So the point is that right now, 2013, we are in a stage in which we are trying to redefine dementia because we have recognized that Alzheimer's, in many cases, does involve atherosclerosis and hardening of the arteries in the brain. Okay? So this is to your left, this is an MRI scan. Okay? So this is an MRI scan. This is the normal fluid-filled areas of the brain. They're a little bit enlarged. And all these white areas, now in the brain, the cortex, the surface of the brain is where the neurons are. And then as you go deeper in the brain, you have the white matters. And again, the white matter is like the streets, the roads. So you think of what you want to do and you send the information through white matters to other part of the brain. So this is an MRI showing extensive white matter disease here, and all these areas from atherosclerosis in a patient with dementia. Okay? So the point is there are many mechanisms of dementia, and what we now consider Alzheimer's disease is an overlapping between Alzheimer's and vascular disease for the most. So dementia, any memory problem that affects your ability to function independently is called dementia. That's the big umbrella, dementia. So in dementia, the more common cause of dementia is Alzheimer's disease. And there's a lot of overlapping between vascular dementia, meaning caused by problems with the blood flow. And there's some people that have only vascular dementia, like multi-infarct dementia. We used to call that Binswanger disease. And there are many others dementia. Not all of the dementias are Alzheimer's disease. Some people have frontotemporal dementia. It's kind of a variant of dementia. They tend to have more behavioral problems, more hallucinations. Creutzfeldt-Jakob, which is like the mad cow disease for humans. Corticobasal degeneration, progressive supranuclear palsy, and others. So dementia, there are many. Within dementia, the more common, Alzheimer's disease. Okay? Everybody's with me? Great. Let's go to the practical things now. So what about genetics? What about genetics? Well, the interesting thing about it is that the more we look at genetics, the more we realize how many diseases have genetic factors. It seems to me like every few months, when I open my journals, there's a new article with a new gene that contributes or predisposes to dementia, as to many other diseases. We have a lot of genes that predispose to Alzheimer's disease. Normally, we don't check that because most of those cause Alzheimer's in younger groups. And right now, if we find out that you have some genes that predispose to Alzheimer's, we cannot change your genes. So we don't do this expensive testing because there's no practical purpose at this time. But it's interesting that we're getting all this information about the genetic factors because as drugs get developed that maybe target specific mechanisms of the brain, we may be able to control at least some types of dementia somewhat better. So when you come to the doctor's office, you come to see a neurologist or your family doctor because of memory problem, okay? So the first thing the doctor has to do is a good history and physical examination, and trust me, if they don't take enough time to sit down with you and get the information, get another doctor. So the history and the physical examination, particularly the history, is the more important thing. Let's go down. Rarely we have to do a brain biopsy. If you need a brain biopsy to diagnose the problem, trust me, it's a bad problem that you have. Lumbar puncture, we used to do them more often. We don't do them as often. They're helpful, particularly if your family members are having a rapidly progressive dementia, meaning a dementia changing over a few months, particularly if they're having fever, malaise, and other symptoms, weight loss, anorexia. You may consider, as a doctor, doing a spinal tap. Genetic testing, we're getting more and more information. It's not recommended to be doing them for most cases. The exception to that would be people under 40 and 50 that have family members under 40s and 50s that have dementia. Those, it's probably a good idea in some cases. Every once in a while, we see patients that are having depression, anxiety, sleeping difficulty, and many other medicines. And sometimes we have to do or send them for a neuropsychological testing. We don't do those all the time, but sometimes they're useful. So the blood work that we do for dementia, so if you or your loved ones go to the doctor for evaluation of dementia, these are the things that your doctor should be checking. A cell blood count, looking for anemia and looking for other blood disorders. A comprehensive metabolic profile, it's just a chemical studies, to look at the kidney and the liver function test. Thyroid function test, B12 level, B1, and then in some cases, syphilis and HIV testing. So if you take your family member or yourself and your doctor recommend, you know what, let's check a syphilis testing or an HIV, don't take it personal. We're not making a decision often based on how you look. We're making it because we know is a possible cause of dementia that can be treated or can be improved. So you don't want to miss it as a doctor. You want to check the blood sugars because your hemoglobin A1C, which is one of the measurements that we do looking at patients with diabetes, if it's consistently over 7.5, it increases by 10 times the risk of dementia. So those of you diabetes, take your diet seriously. Often we like to do some kind of brain imaging study. Okay, so brain imaging are studies to take a look at the brain, and we have either CAT scans or MRI. Now we think of the MRI as an X-ray test. Actually, there's no radiation, there's no X-ray. It's a magnetic field. It costs, $1,200 to $1,500. It's better for most cases. The CAT scan is cheaper technology, costs about $500. And for the most, particularly for elderly patients with memory problem, a CAT scan is adequate way to look at the main things that can cause treatable causes of dementia. One of the new kids on the block in evaluation of patients with dementia are the amyloid scans, the PET scans of the brain. And there's one that got approved just last year called the amyloid CAT scan. Remember, we talked about how amyloid gets formed in the brain, and it leads to some formation of some lesions on the brain, the plaques. That is a hallmark of the classic Alzheimer's disease. So we have a way now to do a scan, look at the amyloid. The problem with them is that it doesn't rule out Alzheimer's in all cases. There's some false positives, so we don't do them in all patients. I think it's important for young patients, people progressing rapidly, or having some unusual features. So I have a lot of patients that come to my office and I say, oh, I want a PET scan. And sometimes it's a good idea, but often it's not. So if your doctor refuses to do, like I do sometimes, it's because it doesn't often add a lot of information to what you know already if you take your time as a doctor to check the patient well. So how do you treat dementia? Let's say we rule out the blood work look okay, the MRI or CAT scan show maybe some age-related changes, atrophy. The brain shrinks as we get older. So if all of us have an MRI or a CAT scan, there's probably a word atrophy on it. That's kind of normal, providing that it's not too bad. So how do you treat and what can you do to help delaying Alzheimer's or help preventing or make it more stable once the symptoms are already hitting? Mental and physical exercises, you can see that we have it as a number one. Okay? Nothing has been proven to help protecting the brain against Alzheimer's better than exercise. So when your doctor tells you, get on your feet, do some treadmill, do some stretching, get into the water, we're not just picking on you. It does help. Often it's important to remove all medicine that can cause confusion because, as you know, we doctors, we're very good adding new medicines, but have a hard time taking off medicines. Treatment of high cholesterol or hyperlipidemia in general. I shouldn't have mentioned cholesterol because that's not the only problem. But treatment of hyperlipidemia is important. Hypertension therapy, and just this week on the news there was an article talking about beta blockers, how people on beta blockers, which are commonly used heart and blood pressure medicine, do have a slightly decreased incidence of dementia. Cutting down on the smoking, treatment of diabetes, and then the use of antiplatelet agents because all of the things decrease stroke and decrease vascular disease. So the same things that help preventing heart disease, they help prevent strokes and they help prevent dementia. Once we diagnose somebody with dementia, and you can fairly well make a diagnosis of an Alzheimer's type dementia, just examining the patient and getting the history and ruling out other things, there's a few medicines that help. And there are 4 medicines approved for treatment of dementia. The first 3 here, donepezil, rivastigmine, and galantamine, are on the family of the cholinesterase inhibitors. What they do is that they inhibit the destruction of acetylcholine. Acetylcholine is a chemical in the brain that is important on the memory pathways. So we block the destruction, we allow more acetylcholine in the brain, so we improve a little bit the function of the brain. They all work about the same. Not really one of them is much better than others. Aricept is the one, or donepezil is the more commonly used one. It's the older one. It's a once a day, comes in generic. Exelon now comes in a patch, which some people like to use. And galantamine is the one that the VA has because they can get it cheaper. It works about the same. They all cause nausea, stomach upset, loss of appetite. Not in everybody. Remember, whenever you read the list of side effects, think that those are things that can happen in some people. If the side effects of the medicine would occur in the majority of patients, that medicine wouldn't be on the market. So when you read the side effects, look at the incidence, and these medicines tend to be very well tolerated. There's another group of medicines of which Namenda is another one. This, I was very excited when it came out to the market a few years ago. We thought this was going to be a big shot. It helps some people. It helps in moderate to advanced dementia. None of them are a cure. All of these medicines help a little bit controlling the symptoms, in some people better than others. We use them often, which is the best thing we have, not because they're that great. If you or your loved ones are taking any of these medicines, the cholinesterase inhibitors, most of the studies were done with evening dose, and sometimes it can cause sleeping problem. So many people feel that it's better to take in the morning. If one bothers you, try another one. Rivastigmine, which is Exelon, comes in a patch. So some people find it better to use. Most people feel it's not a difference. And I like the fact that these medicines, sans goodness, are now coming generic. So they're becoming to a price that is more accessible. There's some new dosages on this medicine. That new dose came when they were losing the patency. It doesn't seem to help that much. So what about natural supplements? If these medicines don't help us good, what about nature? What does nature give us? Well, sometimes we forget that the medicines that we have, they also come from nature for the most. And there's a lot of medicines, there's a lot of natural products that people use and are very popular in the world of natural healing. And this is the data on some of those. Ginkgo biloba. It was heavily advertised and publicized back in the 90s One of the few plants that survived the Hiroshima bombing, you know. So hey, if it survived Hiroshima bombing, why is it not going to help me for Alzheimer's? But it doesn't work quite like that. I used to prescribe it some, but some studies have shown increased incidence of bleeding in the brain. You don't want to use it if you're taking any blood thinners or you have any bleeding tendencies. The NIH, National Institute of Health, did a study, 3,000 patients, showing no benefits of ginkgo biloba. I still have some patients on it, but I always tell them there's no evidence that it helped. This is another favorite of the holistic people. I don't know how to pronounce this. Huperzine, however it is, that's the way to pronounce it. It works similar to the main medicine for Alzheimer's disease. A recent study has shown of no benefit. Honestly, if you're taking this one, you might as well take donepezil or one of the medication, because you know exactly what you're taking, you know the dose that you're taking. It's right now, with the data that we have, it's not worth it. One of the big new kids on the block on natural treatment of Alzheimer's disease is being the coconut oil. Okay, if you read some literature about it, it's become very popular. The mechanism of it is very interesting, but I have looked at the data, and the fact is that the studies have not shown that it helped much preventing Alzheimer's disease. I tell my patients, why don't you go and have a coconut sherbet, you know, for $70 a month that it costs, have a coconut sherbet twice a week, you know, go to a high school sport game once a month, go to the movies once a month, and use better use of your $70 a month. But there's a couple of other ones, very important ones. CoQ10 is a good antioxidant. I think it's a good product. Seems to be good for cholesterol and good for the heart. There's not a lot of data on Alzheimer's disease. A patient that asks me, I tell them, if you want to take it, try it, but we don't know if it helps. This is another one, and the point is that the natural supplements, you know, there's no strong evidence that they help a lot. My recommendation to patients is eat healthy. Eat healthy. Sanjay Gupta, which you probably know, is a CNN medical correspondent on his book that he published a few years ago on aging. Excellent book, by the way. He made a comment that the most common mistake users of herbal remedies make is believing that the substance they take actually works. So I know you're being a little bit depressed with my talk today. I have the feeling you are. The medicines don't work as good. The natural supplements don't work as good. If we live long enough, we're going to get dementia. Can I say something nice? So what about treatment failure? Does that mean that if the medicines don't help us good and the natural supplements don't help, there's nothing to do? No, there's not. There is a lot of things that we can do. This is an information that I give my patients. I call that the 15 suggestions to improve your memory. And any age is a good age to start. Number one, schedules. People function better when they work on schedules. We did it with our kids when we were raising them. With our senior family members, it works as well. If you're used to get up at the same time, wake up, have your meals at the same time, exercise at the same time, the body gets used to routines. As you lose your mind, you continue that routine a little bit better. So that's what I'm doing with my wife. I'm training her to do things on time, do things organized, so when she gets dementia, she can still function better. Low carbohydrate diet. Big problem that we're having in this country, but not only us, the Middle East, 100% increase in obesity. China, tremendous increase in obesity. But here, the numbers are catastrophic. We need to focus on a low carbohydrate diet, have your 3 meals a day, plenty of fruits. You want to look at your plate when you're eating and see colors. You want to see yellows, you want to see greens, you want to see reds. Color in food means freshness and different nutrients. So you want to keep an eye on that. Exercise. We've been talking about it already. Any kind of exercise. No excuse. I have in my office a list of wheelchair exercises. So for those that tell me, oh, I cannot exercise because I'm in a wheelchair, I said, okay, I have a list for you here. Get a little bit of sun. Staying indoors is not a good idea. Cut down on your smoking. Engage in activities. Get some chores. The wife loves when I put this one. Stay well hydrated. Get involved in social and family activities. Okay? The more busier you are, the more active your brain stays. Contact old friends and form friends with known warriors. Plan something enjoyable every day, learn a new skill, play cards or a board game a couple of times a week, listening to music, and consider going to the church or religious service of your choice. And trust me, there's a lot of that, and any books you read on healthy aging, this is the summary of it, the things you need to do. So there was a study recently that showed that a good marital life was better than a low level of cholesterol in terms of projecting or predisposing to a healthy longevity. And just getting out of the house is enough to cut in half your odds of developing Alzheimer's disease. So get out, grill, work on the yard, do a cookout, do a picnic every once in a while. All those things will fill your heart and will also maintain your brain. A good meal, you want to eat healthy. You want to go out every once in a while. You want to have your glass of wine. But when I said a glass of wine, it means one. Drinking is a problem, a lot of side effects with drinking, so you want to eat healthy. Have a date night. You know, one of the problems when we retire is that we don't have anything to look forward. You know, we don't have a schedule, we don't have a plan, you know, and it's good to have those. Now, you want to get out of the responsibility. You don't want to put a lot of strain in your life, but you have a date night, have a game night, have a movie night. You know, make sure you have, again, something to look forward. Diet is important, and I'm not a dietitian, but I think there's a couple of things that are important to talk about. You want to limit the carbohydrates. Some people would say eliminate the carbohydrate, but at least limit the carbohydrates. Eliminate the rice, or cut down the rice if you're going to eat it, small amounts, brown rice better than white. Pasta, whole wheat, cut it down, even if you're Italian. Potatoes is a heavy load of carbohydrates. You know, get rid of the ice cream, get rid of the sweets and bread. You need protein, get some fish, get some meat, ideally grass-fed, it's a little bit more expensive. Shrimp, nuts are really good. Proteins, the peanuts have a lot of allergens, but all of the other nuts is a very good source of protein, it's a good snack, so you want to do that. Fats, there's some fats that are really good. Avocado, olive oil, coconut oil. One of the things we're doing at home is most of our meats and fish, put a little bit of olive oil, put some garlic, put the meat on, you know, and easy cooking, fresh food, healthy food. Fruits and vegetables are crucial. Grains, you know, it's a lot of debate on the dietary people about how bad are they, how good are they, but for sure, they're not a great source of nutrients. They tend to be unhealthy for the gut, and they have some pro-inflammatory activity, so cut down on the grains a little bit, at least. What about exercise? I don't get tired of mentioning that, but listen to this. Exercise improves circulation and cardiovascular status. It's the best treatment for osteoporosis. It can delay and control the 8% muscle mass that we will lose every 10 years after age 40. It's the only proven treatment to delay age-related memory loss. So if you're having memory loss already, exercise. If you think you're going to get memory loss or you may get into there, exercise too. And no matter what the doctors say, smoking is bad. Smoking is bad. So if you're still smoking, beginning of 2013 is a good time to go down on your smoking. There's a number of studies looking at longevity and healthy longevity. There's been very interesting studies in Japan, in Okinawa, in some places in South America, in California. There's some groups of people that they live long. And in Boston, they have the Boston longitudinal studies. And they did a study. They took people over 100. They evaluated everybody they could, trying to figure out what does it take for a healthy longevity. Well, most people that live long and stay healthy, they have a few things in common. They stay active, physically active and mentally active. They do have little weight fluctuations. They eat in moderation, and they tend to have little worries and good humor. So it is important to have fun. Very important to have fun. So if you exercise, eating healthy, you know, having a good time with your family, staying in touch with your children and grandchildren, making everybody in your family proud, you have a better chance. I mean, just still get dementia if you live long enough, but hopefully you live longer with a healthy brain. But at some point, we'll face our loved ones having the more severe effects of dementia. And one of the big problems that we face is the driving. So we see a lot of patients that come to our office with the question of, can I drive? Can my husband or wife drive? Let me tell you something, and please remember this. I shouldn't be the one telling you if your husband or wife shouldn't drive. You're the one driving with them. I mean, you need to tell us, listen, my husband is a danger to society. Or my wife, it shouldn't be driving if she doesn't want to give up the keys. You need to tell us that. Don't expect that in a 20, 30, 40-minute evaluation, we'll have a better idea than you have about your loved one. So when people look at the factors that when do we become concerned about the driving, the family perception of a driving problem is the main issue that we take in consideration. There's other factors. We do often in the office what's called a mini mental status, which is a questionnaire of 30 questions that give us an idea of how the memory is working. Of 30 questions, if you have less than 24, we should start considering not to let you drive. If there's a problem with impulsivity, previous accidents or citations, those are the things we take in common to tell family members, no, you shouldn't be driving. One of the biggest problems with Alzheimer's, and I always tell my patients, dementia is not that bad. I mean, it's going to come. So, I mean, don't be scared about it. You need to prepare for it, But I know it's easier said than done. But one of the really bad problems with dementia or Alzheimer's is when we start having behavioral problems, psychosis. Psychosis is when we lose the perception of reality. So hallucinations, seeing people, hearing voices, those are hallucinations. That's a form of psychosis. Behavioral problem, I saw the other day this lady, 80 years old. The husband was like 85. And she was accusing him of having many children with this other woman. And trust me, that man could do nothing. But those are some of the more common psychotic features: behavioral problem, aggression, hallucination. How do you do to help control those? Again, easier said than done, but keep the patient active. Avoid stressing factors. Do an activity program. Make sure you keep them in schedule, get them out of the house, get them to get some sun, put some light music, put them on routines. And clearly, many of these patients need medication. Now, interestingly enough, for psychosis, the worst problem of dementia, or one of the worst problems, the best medicines don't work as good. The antipsychotics, actually, there's a black box warning because they can increase incidence of arrhythmia and heart disease in the elderly. So what are we facing in this country? Patients come to the doctor, my husband, he's throwing things, kicking out, he's aggressive verbally and physically at me. How do I handle? And then the doctor response is, I'm sorry, I cannot prescribe the best medicines we have because of the risk of mortality. So we're facing a huge problem in how to treat these patients. The aging brain doesn't respond as well to many medications as the younger brain that have some problems. So there's a lot of drug development, but one of the biggest things that is going to happen in Alzheimer's, hopefully in the next few years, is better treatment for behavioral problems. But not everything gets solved with medication. This is a list of symptoms of psychosis, delusions, hallucinations, agitation, aggression, depression, anxiety, insomnia. We have treatment for all of those. They're hard to treat, but if you're having your loved ones with any of these problems, just make sure you obviously discuss it with your doctor. One of the more important things is, for us, caregiver support. Now that we have all this medicine for Alzheimer's disease, we often think that a patient come in, they have Alzheimer's, we put them on whatever medicine and go home and we did our job, and we're failing to give the family members good support. So this is a slide that I have for a conference that I did for a group of doctors and nurse practitioners, emphasizing that as a doctor and a practitioner, the most important thing that we can do is help the caregiver. Help the caregiver is important. We need to give them emotional support. We need to provide resources. There's a lot of resources on the community, including information on support group, community assistant, home health, financial services, and advanced life planning. So the biggest question that often we face, one of the toughest one is, I'm having trouble caring for my loved one. You know, what do I do? When should we consider placement of our husband, wife, father, mother with dementia? It's one of the toughest questions that we face as doctors and obviously family members face. My answer to the patients is, you're going to have to tell us when you're ready. I mean, if you're taking care of a loved one with Alzheimer's disease and you're having trouble caring for them and you're not sleeping well, if the patient start having behavioral problems, aggression, unsteadiness with high risk of falls, incontinence, and at the time that they become unable to recognize family members, those are times in which you don't have to, but you should be considering the possibility of placement. What about long-term care? It's interesting to see what's going on in the world about this because we're facing an aging population that we're going to have a harder time taking care of. But we're not the only ones. Japan is worst. Europe is worst. In the US, the average cost of a nursing home care was about $76,000. It's about $200 a day. In Germany, what are they doing? The new trend is putting patients in nursing homes in other countries where healthcare is more affordable. Now, hey, I have a lot of respect for the German people. Good, well-organized people. We're not talking about the 1940s. We're talking about today's Germany. They take very good care of their loved ones. And obviously, there's a lot of countries surrounding Germany. So it's easier to put them in Poland or the Czech Republic. You know, we had a harder time putting them in Mexico or south of the border or whatever. In Japan, the spouses or children of the elderly people have traditionally provided long-term care. However, in the year 2000, the Japanese government initiated a mandatory public long-term care system insurance to help older people lead a more independent life. This is another system. Here we're fighting to maintain Medicare and Social Security. In Japan, they're adding a social system to help the elderly. It's going to be interesting to see how it goes with their plan. What about palliative care and hospice? Palliative care is a branch of hospice, and if your loved ones are having incontinence, inability to feed themselves, inability to bathe themselves, difficulty with communication, they're candidate for palliative or hospice care. Now, palliative and hospice care doesn't mean throwing the towel for them. The opposite, getting a towel to help them. They provide a lot of services, is covered by Medicare, so it doesn't involve any cost from the family members. So palliative care, which is the active total care of patients whose diseases are not responding to curative treatment, is something to consider when our loved ones are severely disabled. And sometimes we doctors tend to forget about this important message of one of the more famous physicians of all time, which means that the art of maintaining the health is not the art of averting death. Sometimes we just keep on treating and treating and treating patients, and sometimes there's a time that we have to say, you know, I'm not here to prolong disability. I'm not providing health to your loved ones. I think we need to look into hospice care, and that's a big trend going on, and it's a big problem to deal with. Because the art of maintaining health is not the art of averting death. Important concept in medicine that doctors seem to fail to understand many times. We're running late, but I have a couple of slides that I really want to show you. And again, we're going to big time science now. But right now, while we have no preventive medicine and not great medicines to treat Alzheimer's disease, we have ways to measure who will develop Alzheimer's disease. And this 0 is the age of onset of Alzheimer's disease patients. Here is 10 years within the disease. This is 10 years before, 20, and 30 years before people develop Alzheimer's disease. So now we know that if you do spinal fluid and you measure amyloid protein or tau, and if you look at MRIs and you measure the hippocampus, and you do PET scans and look at the glucose metabolism, we can detect 20 years, 10 years before people develop Alzheimer's disease, who is at a higher risk of getting the disease. So if we ever get good treatments, we have ways to evaluate who's going to be getting Alzheimer's disease a little bit earlier and approach the treatment before. People are looking into pacemakers of the brain. Very interesting data. Putting leads in the brain that stimulate some areas that have to do with the memory. This is a new trend. There's studies going on at the University of Florida, up north here. The people are still looking at stem cells and the effect on the brain. That's a technology that still has some provide dividends for the brain. And this year, 2012, this past year, for the first time ever, we started doing some studies on Alzheimer's prevention. They took patients that have genetic predisposition for Alzheimer's disease. They have 3 drugs that help blocking the amyloid formation. And we're evaluating those studies are in progress to see if we finally are able to get any drug that will hopefully help better Alzheimer's patients. Why are we doing these studies? Well, because a delay in onset of Alzheimer's disease for 5 years will have an effect of reducing the prevalence by 50%. It will have a big effect. Don't count on it. I'm not counting on it. I'm younger than most of you here. One of the problems we're facing is that what's going to happen? I mean, we're not prolonging life of people healthy. We're just adding sometimes advanced years. And I like the sayings, meaning the people who are hoping to extend lifespan need to spend more times around centenarians. Because what matters is how well one lives, not how long we live. I'm running late, so I'm holding it there. We're going to stop now, and I'll be glad to take any questions that you have for me. Thank you so much.